Hello everyone. So today we're gonna continue our discussions of the hematology section. Okay, we're gonna continue doing the same, is that cracking down the big case scenarios into small words that lead you to the right answer. All right. So you see, 25-year-old woman. She has a cough, fever, night sweats. Okay. So what on exam there is a cervical lymphadenopathy. Okay. And they ask you, okay, what's best next step? What do you do? This one, the first thing you want to do, excisional biopsy of the lymph node, of the supraclavicular lymph node. You have cervical and supraclavicular. So this is the best way to diagnose if there is a lymphadenopathy for malignancy. So now this brings us to the discussion, what are the worrisome features for lymph node? If it's more than 2 centimeters in size, it's been going on for more than 4 weeks or more, firm, non-tender, or firm or hard, axillary lymph node involvement, axillary lymph node, supraclavicular lymph node, generalized lymphadenopathy. These are worrisome features. And if there is abnormal chest x-ray, and if there are other findings of malignancy like fever, night sweats, like this patient's, weight loss. These are malignant features for lymphadenopathy. Okay. Now, in this case, you see a 57-year-old woman came in because of progressive weakness, and she was diagnosed with a breast cancer 6 years ago. Now you check platelet is like 30,000. So platelet is 30,000. She had breast cancer. What could be causing that? Why is that? So if you're on cancer, they're gonna do chemotherapy, and there are some chemotherapy that can cause platelet to drops really low, and that called anthracycline exposure, which this patient is on, like doxorubicin, cyclophosphamide, and paclitaxel. Okay, so these are could cause like thrombocytopenia, and has a lot of side effects. Cause myelodysplastic syndrome as well. It causes acute myeloid leukemia. So that's the idea of this question. Basically, they want you to know like this doxorubicin and the anthracycline drugs can cause MDS, AML, okay, myeloproliferative neoplasia, okay, can cause all kinds of neoplasm. Now you see a patient who's 72-year-old man comes in with fatigue, smoker. So you do platelet is very low, it's 160,000. ACLT a little bit elevated. Peripheral smear shows ovalo-macrocytic RBC with reduced granulation segmentation. Reduced granulocyte segmentation. This means the neutrophil segmentation is less. This means there's a production issue. So, and then you see the white blood cell count is low. So this one you have low platelet, low white blood cell count, hemoglobin is low as well. Like hemoglobin would be 8, white blood cell count will be low, like 3,000. Platelet is 30,000. So what is going on in here? This one you think there is a production issue, like the bone marrow is not producing enough RBC, platelets, and leukocytes. So what's the best next step? You need to do bone marrow biopsy. Okay, that would be very good next step to see, because this is myelodysplastic syndrome. So how does that myelodysplastic syndrome present? Usually you have refractory cytopenia, anemia, thrombocytopenia. You can see can present with single lineage dysplasia, can cause ring sideroblast, can cause chronic myelomonocytic leukemia, can cause refractory anemia with excessive blast transformation. So these are the different types, and how the way to present like this: easy bruising, fatigue, weakness, angina, recurrent infection because the segmentation in the craniocyte is going to be reduced. So that these are the possible causes that can this presentation. What are lab finding? Usually you can have normocytic or macrocytic anemia with low reticulocyte. This is a big one. And then you have leukopenia, thrombocytopenia, and then hypercellular marrow with single or multi-lineage dysplasia on the biopsy. Okay. And that's how you diagnose myro proliferative, like MDS, myelodysplastic syndrome. Okay. Now you see somebody who's like you see 71-year-old have localized prostate cancer. Okay. So what treat him with radiation, and they ask what's the complications of that. Complications is sexual dysfunction. Okay. Sexual dysfunction can be a complication with a local prostate, and also depend on the technique. Where do you do radiation? Variable. So you may need sildenafil to help a little bit with that sexual dysfunction. Okay. Now they give you a 64-year-old had a breast cancer, so she's on tamoxifen. Now need hip replacement. So what's best next step? You hold tamoxifen 2 to 4 weeks before surgery. Okay. Why? Because it's increased risk for thrombosis and venous thromboemboli, and we don't want that, you know, so that's why we wanna hold that. Alright, now you have this patient who's 36-year-old man, came in with sore throat. You examine him, there is cervical lymph node, like 2 centimeter. So after you palpate it, you see like there is another posterior cervical node, like 0.5 centimeter. So you just follow up on that patient, okay, after 4 weeks. So after in the 4 weeks follow up, what do you see? You see the anterior cervical lymph node decreased, okay. So this is the how they want to trick you. Like after 4 weeks, lymph node size decreased, but still like so decreased from 2 centimeter to 1.5 centimeter. And I tell you what's best. What is the diagnosis? What is it? Is it Epstein-Barr virus? Is it mycobacterial infection, or is it neoplasm or cancer? So they want to trick you. They're telling you the lymph node decreased, but in reality, if there is an infectious lymph node, it should disappear completely in 4 weeks. But having the fact that it just persisted, even if it's decreased, this most likely is a lymphoid lineage neoplasm. Okay. So now this brings us to the discussion. If you see somebody with lymphadenopathy, it's differentiated based if it's generalized, it's all over, or it's localized. If it's generalized, then it could be HIV infection or mycobacterial infection, infectious mononucleosis, SLE, or drugs like phenytoin can cause this generalized lymphadenopathy. But if it is localized, then you gotta be a little bit more concerned if it's localized. If it's cervical, then it could be infection or malignancy. If it's supraclavicular, it's most likely malignancy. Axillary as well can be infection or malignancy. Epitrochlear could be syphilis, sarcoid, or lymphoma. This is used to be screening with the prostitute. Sure, look at that. If there's this, if there's lymph node, this could be syphilis. Okay, and there's inguinal lymph node, like this could be caused by STD or malignancy. Okay, So what do you do with these situations? So the way you want to do, you treat underlying cause and follow up in 3 to 4 weeks. So after following up in 4 weeks, see if it's resolved, just routine follow-up. If it's persist, then you do excisional lymph node biopsy, okay? So that's how you usually deal with the lymphadenopathy, okay? So now you have this patient who's 76, had advanced colon cancer, like a sedentary lifestyle, like need help with ADLs, activity of daily living, and they tell you what is the most important predictor in a prognosis. What's the predictor of the prognosis? Prognosis is poor performance status. Because he is sitting at home most days, this is very high risk for complications. And may not do well with chemotherapy. Okay. Now that brings us to the performance status. How do you evaluate people, like if they're going to do well with chemotherapy or not? There are different performance status. There is this scale, Karnofsky performance status. If it's 80 to 100, like if somebody's able to perform activities, work, and no special need required. 50 to 70, like a patient live at home and care for most personal needs, but unable to work and some assistance needed. So 80 to 100, able to work. 50 to 70 can help themselves, but they can't work. 0 to 40, unable to care for self, require hospital or institutional care. This one means rapid disease progression is likely, okay? Like they're in and out of the hospital, they're in nursing home, they can't take care of themselves and they can't work, okay? So taking care of yourself and work, okay? These two things. If you do both, that's good. If you like one, that's like medium. If you can't work, can take care of yourself. If you don't like, you don't have any of them, then this is very poor performance status. You may not do very well with chemo. Alright, now you see 27-year-old woman came in because of low platelet, 50,000, okay? This is very low. You check hemoglobin and you check rest of the labs, seems okay. So what would you do for this patient? Best next step, just do observe, okay? Why? Because this patient has immune thrombocytopenic purpura, okay? How do you manage immune thrombocytopenic purpura? The one you look for, if it's the cutoff is 30,000, okay? If it's above 30,000, no bleeding, you just observe, okay? If it's less than 30,000, then you give steroid or IVIG. This is the first line. And then you assess. If it improved to more than 30,000, you observe. If it's still less than 30,000, or there's a bleeding, plus minus a bleeding. If there's a bleeding, then you give that treatment regardless, okay? So if there is a platelet less than 30,000, still after that didn't help, then you go do splenectomy or rituximab. If it's improved, you just follow up. If it's still no response, then you do thrombopoiesis stimulating agent. Okay, this is the third line. So this is the first, second, third line management of the immune thrombocytopenic purpura. Alright. Now you have this very interesting case. You see a 61-year-old man came in from India. He has fever, weight loss for 3 months, and there is a right flank pain on deep palpation. So you do regular labs, you see hematocrit is 54%. Okay. You do urinalysis, shows 5 to 10 RBC per high power field. This what does that make you think? Okay, diagnosis. There's fever, weight loss, hematuria, hematocrit high. This could be make you suspect renal cell. This could be renal cell cancer. Okay. And you may ask yourself, how does it present? Can be asymptomatic, or it can cause just hematuria, and sometimes cause abdominal pain, weight loss, like in this patient, and it can cause scrotal varicocele. What are the paraneoplastic syndrome of renal cell carcinoma? It can cause plenty of things. Anemia is one of them. Erythrocytosis, increased erythropoietin production, so it causes hematocrit to be high, and cause non-metastatic liver function abnormality. LFT will be high a little bit as well. LFT can go up like in any stress in the body sometimes. Fever, weight loss, hypercalcemia if it secretes the PTH-RP or prostaglandin, and can cause amyloidosis. Okay, so these are the things that you want to know for renal cell carcinoma. Okay, now this case is unfortunate, like 23-year-old woman. She's very young, she has lump in her neck. Okay, we said if it persists lymph node, you do biopsy. So biopsy shows a CD15, CD30 lymphoma. Okay, and large multinucleated giant cell. What would you do right now? So have her see fertility specialist. See what are the options to preserve her fertility, because she's gonna undergo chemotherapy that's gonna probably destroy her chances of having a baby, and that's not good, you know, that's cruel. So you want to refer to reproductive endocrinologist as early as possible to avoid treatment delays. So now that's what we discussed about. We discussed about lymphoma management, fertility, renal cell carcinoma. We talked about ITP management. Okay. How do you manage it? We talked about cancer performance, lymphoid neoplasm, lineage neoplasm, tamoxifen could cause thrombosis, sexual dysfunction, prostate cancer, radiation, bone marrow biopsy for myelodysplastic syndrome, anthracycline side effects can cause MDS, and we talked about how excision lymph node biopsy for persistent lymphadenopathy. And that summarizes our session of this hematology section. Thank you for listening.